Welcome to the rtx1 e-symposium. We are very glad to have today among our guests our two chairs, Professor Peto from Queen's University, Belfast, as well as Professor Errera from Pittsburgh School of Medicine. You might already know that the rtx1 adaptive optics camera has been already used in more than 200 published articles that can be clinical studies or reviews. And we are very happy that today 6 presenters will tell us more of what they are doing in terms of cellular level retinal imaging and microvascular retinal imaging in their research using this device. So Professor Peto, she has a main interest in diabetic retinopathy in her research, but recently she also works on various research projects that covers retinal image analysis in neurodegenerative diseases, and that includes adaptive optics imaging. I'm going to leave them to introduce the speakers of the first session.
Thank you very much, and I would like to welcome you all, and thank you very much for joining. I hope you will have a great time on this webinar. So we'll have 3 distinguished speakers today, and they'll be talking about slightly different issues, and hopefully that will give you a flavor on what's going on in adaptive optics. Our first speaker is Imre Lengyel from Queen's University, Belfast here in the UK, who is also sort of working on neurodegenerative diseases and looking at how retinal imaging might give us some new insight. Imre is a basic scientist who is very much interested in translational research, and I will hand it over to him now. Thank you very much.
So, as Tunde mentioned, I'm interested in neurodegeneration and using the eye as a potential marker for neurodegenerative diseases. But I'm lucky to be part of a very wide collaborative network in Queen's University, and also other institutions within the UK, and hopefully soon internationally. Our major interest currently is on multiple sclerosis, Down syndrome, and Alzheimer's disease. And Tunde asked me to give a little bit of flavor of our approach and highlight how adaptive optics fits into the overall picture. You all know that the eye share many similarities to the brain, embryologically, functionally, in many ways. And imaging the eye is very simple. Therefore, it could be a good sensor. You can look at vasculature, you can look at myelination, you can look at neuronal losses. The problem is that currently what we can do lacks specificity. The same sort of measures appear in different conditions. Multiple sclerosis, Alzheimer's disease, Parkinson's disease, and stroke are just a few of those. Therefore, we want to know how specificity could be increased. So in our study, we decided to choose a multimodal approach, whereby we look at classical fundus imaging, look at the different features, of course, including the well-known optic neuritis, look at the vasculature with OCT angiography to look at the microvasculature, look at other features like autofluorescence, quantitative autofluorescence especially, as well as pigment density changes in the conditions. And we also want to see whether the peripheral retina is affected in this particular disease and how it relates to other parts. So ultraviolet field imaging with the Optos is part of it. But at the end of the day, of course, is the functional change that is that matters to patients. So you need to measure certain things to be able to get a fuller picture. Today, I will give you just a little bit of flavor of what is that we can get and what we got so far and which is the direction we are doing. But to take this a little bit further, we want to also look at fluid biomarkers. And in this case, we are using the tear as a potential marker. We have not started to analyze this, but we have collected the samples and we are looking forward to step forward with it. What is well known in multiple sclerosis that the inner retina thins, especially in optic neuritis. And that's exactly what we see in our case. Let me just get the laser pointer. When optic neuritis is present in the patient, MSON, then there is a significant thinning of the ganglion cell inner plexiform layer. This is not as prevalent when you look at the whole inner retina, so it seems to be more specific, so those more inner layers. And when you look at the whole retinal thickness, there are not really detectable change in OCT. So we asked the question, is it possible that the outer retina might be affected? And this, for this, we measure the outer nuclear layer where we find no difference. But we do see some changes in the photoreceptor layer. We also see some changes in the outer retinal thickness. So maybe the inner retinal thinning and the outer retinal thickness is the reason why there is no discernible difference between the whole retinal thickness. And there is no change in RPE. So OCT gave us some indication that there are some outer retinal changes. So the question was, is there a cone difference? Is there an effect on cones? And as it turns out, patients that are, whether they have optic neuritis or have no optic neuritis, there is a significant, about 15% less cone photoreceptors, which is reflected in cone spacing as well. So this method seemed to provide us with with a specificity that is for MS, not to a subtype. When we
30 seconds left.
When we looked at visual acuity, we find that visual acuity in MS-ON is changed, as well as contrast sensitivity. But when we look at a wide variety of these different imaging, this is a very preliminary data, we also see that vessel calibers might be something that are more associated with MS than we thought before. So I'd like to finish here by summarizing that we have some changes that are specific for photoreceptors and which has reproduced data, and there are others that are specific for MS, and that might help by introducing multimodality, might help us to increase sensitivity and specificity of this condition. Thank you.
Thank you very much. That was a very good introduction to all of our speakers, and also to the method itself and how we might be able to help with some other diseases as well. So we're going to move on to our second speaker. And of course, we have been all wanting to know what the hyperreflective foci, both in diabetes and age-related macular degeneration, might have been. So I'm going to ask Christopher Holmes from Moorfields Eye Hospital to talk to us about deciphering hyperreflective foci in AMD with adaptive optics and a Pinnacle study. Thank you.
Thank you for the introduction. And thank you for the opportunity to speak today. So yes, I'm Chris Holmes. I work at Moorfields, and I'll be talking about deciphering hyperreflective foci with the adaptive optics camera, and as part of the work with the Pinnacle study. So the rtx1 is able to capture excellent views and enable analysis of the cone mosaic, but in the intermediate and late AMD, this can become challenging to interpret. The cone mosaic can be lost due to progression of disease, but also due to issues with contrast or elevation of the cone mosaic out of the camera's focal plane. So we've been looking at a different biomarker, looking at hyperreflective clumps, at least in parts. So HRCs are a common feature to many stages of macular degeneration, and you can see them here in these black spots. They correspond on OCT with RPE thickening and hyperreflective foci on OCT, which are known biomarkers for disease progression. HRCs, as you can see, are very highly dynamic, and the trouble is their speed and patterns of movement are poorly understood. So the cellular origin of HRF is debated, with candidates including migrating RPE cells and also mononuclear phagocytes. This study was conceived after we looked at a preprint by Rossi and Errera, reporting microglial cell movement in vivo with AOSLO. And that was cells in the ganglion cell layer, but we were looking to do a similar study looking at hyperreflective clumps. So the Migration speed of LPE cells is unknown and the diameter is highly variable in healthy eyes, but we thought we would improve our understanding of HRCs with the AO camera by measuring HRC movement speed and HRC size. We hypothesized that this may enable phenotyping of the HRCs and give an indication of their cellular origin. So in terms of the methods, I've been working in the Pinnacle study, which is an international multi-center study following up patients with intermediate AMD and those who've been progressing to late AMD as well for 3 years, as long as they remain non-neovascular. I've been working primarily with the adaptive optics images, but it's a multimodal imaging study. So in a subgroup of the Pinnacle patients attending between November 22 and January 2023, in these patients who agreed to additional AO imaging, we performed adaptive optics imaging focused at least on one area of highly concentrated HRCs at the level of the cone mosaic, followed by SDOCT and SLO. And then we repeated adaptive optics imaging in the same area as the first image, aimed about 1 to 3 hours later. We then aligned those images using landmarks such as retinal vessels, and once aligned, alternated between the images to identify mobile HRCs. We used image J to measure size of HRCs and also their movement, and we used the AO wall detect, although not strictly within its intended purposes. We measured between landmarks to gain an idea of the number of microns per pixel to calibrate our image J measurements. So moving on to the results. In 24 images from 14 eyes, we measured 448 HRC diameters, and there was a normal distribution with a mean of 15.7 microns with standard deviation of 6 microns. Mean HRC diameter was larger in images that were containing cirrhora or iRora than those that contain drusen. And in this example image, you can see the range of size of HRCs with some of the smaller black dots as well as much larger ones in clusters. The tendency of the HRCs to cluster made counting their numbers and proportions problematic, but you can see in these aligned images that are alternating back and forth that are 88 minutes apart, that HRCs do appear to move, at least some of them. And we found that in every image that we assessed, there was at least one moving HRC. I've identified them here with these white arrows. So we used image J to measure the HRC movement over these timeframes and divided by the time between the images to record the speed, and the greatest speed we were able to record was just under 0.015 microns per second, which is a little slower than the 0.02 microns per second that had been found in microglia. All mobile HRCs that we were able to identify in the OCT were adjacent to the RPE or in the interdigitation zone. This likely reflects the level of focus of our camera. So in terms of the conclusions, the rtx1 camera can capture retinal and cellular movement in vivo with images as little as 48 minutes apart. HRC speed is near that of microglia, but the speed of RPE cells moving is unknown. Their size could be consistent with microglial cells, but again, could be consistent with RPE cells due to their wide range of diameters. HRCs appear larger in images of cirrhora, which could indicate they have a role as a biomarker disease in AMD. The difference in HRC size could indicate different cell lines, such as more RPE cells in later disease, but it could also represent activation of microglia or macrophages. The limitations of our study included the small sample size with a heterogeneous population of intermediate and late AMD.
Sorry, it's time to conclude.
All right, but you can see the rest of the limitations there. So I'd like to acknowledge my colleagues on the Pinnacle trial. Thank you very much.
Thank you very much, and we'll have some time for discussion soon enough. So hoping that everyone will have questions. So keep posting your questions in the Q&A. So the last speaker in the first part of this session is Friederike Kortum, who's from the University Hospital of Tübingen. And she will be talking about morphometric analysis of retinal artery and RPE65 associated RP patients treated with vorticine and parvovac. Friederike.
So thank you for the introduction. Yes, I want to show you our results of an analysis with patients treated with Luxturna in RPE65 associated retinal dystrophy. What we basically wanted to know if the arterial architecture changes. So we examined them with adaptive optics. It's targeted patients with RPE65 mediated congenital amaurosis type 2 or early onset retinal dystrophy. So our cohort was basically all 16 eyes that were treated at our clinic in Tübingen. However, only 6 eyes were for patients were able to be followed up. That was due to malfixation issues or patients who were too little. And also over time, it was difficult because our observation period was 12 months and the follow-up positions were sometimes too blurred. So that was the reason we were only able to include 6 eyes. In these 6 eyes, we looked at 5 different positions at each eye, and we measured the lumen diameter, the wall-to-lumen ratio, and the wall cross-sectional area in all these patients. It's with the manufacturer's software, so with rtx1 software provided. I want to show you here in one example how it looked. We chose 5 positions on arterial or arterioles that were easy to access and to follow up over time. Here you see now one spot, measurements taken on the left side in one patient over time. And on the upper row are the baseline examination after 2 weeks, 4 weeks, and underneath 3 months, 6 months, and 12 months after treatment. On the right side, you see a healthy individual, and you can, if you look closely, see that the borders of the vessels are not really well defined. So I just wanted to point out here that measurements sometimes were not easy, and that was also the reason why we had to exclude some patients. And even in the ones we included, it was not always easy and easy to follow up. So our patients cohort or the eyes were roughly 19 years old. Their bulbous length was quite, like in the normal population. We could see that the wall-to-lumen ratio of 12 months stayed stable. However, the lumen diameter and the wall cross-sectional area changed significantly, and post-hoc t-test showed that it was basically between week 2 and 4. So we saw a drop after 2 weeks, and after 4 weeks, it came back to norm. In all images we took with adaptive optics, there were no signs of inflammation, such as sheathing or deposits or inflammatory cells, such as macrophages. We also examined them at the slip land, but there was also no inflammatory response. We concluded that there was no sign for inflammatory changes, and this is very important regarding further developments of genetic treatments. We also discussed that the decrease of the lumen diameter and the wall cross-sectional area shortly after treatment, so after these 2 weeks, might be also caused by perioperative prednisolone intake. And so we basically wanted to point out that there was no measurable reaction on the vessels regarding safety when introducing viral particles with genetic treatments, and it might be a further relevant question for other treatments. Our study has been also recently published. Thank you.
Thank you very much. So I would like to thank the first 3 speakers, and I hope that the audience enjoyed the talks. So we've got a couple of questions to Christopher, and then I come back to Imran and Frederica. So the questions are is it possible, how do you confirm that you were really looking at movement and not at a change of the image angle between frames?
So it's a good question. It was actually very difficult to do in certain images. So we tried to make sure the images were centered on the same area as much as possible due to the sort of the gaze-dependent changes that you see in the adaptive optics imaging. And generally speaking, when sort of aligning the images, the aim was to try and minimize the amount of movement at all between the two, so the changes visible. So for example, the alignment that I showed you was as close a match as we could get between those two images, and the movement that our eye was able to detect was the HRC that appeared to be moving.
And a related question before we move on is that, why do you think the HRFs were so dark?
Yeah, it's a good question, and not because HRFs obviously appear hyper-reflective on OCT, but I think it's because OCT is kind of measuring a different metric. It's looking at backscatter of light, whereas the flood illumination adaptive optics, it looks like scatter, and it's kind of a different measurement of melanin. We think it is the melanin that's been phagocytosed by, well, it's either phagocytosed by macrophages or it's in RPE cells is what's causing that hyper-reflective signal.
Thank you. So, Imre, where do you see the role of AO in the upcoming studies? You have spoken about the MS study, but you also have patients with Alzheimer and Down syndrome. Do you think it's feasible for them to complete this examination? Are we going to be, and what are the main clinical advantages potentially for doing this in a neurodegenerative disease spectrum?
I do think it's feasible, especially because it's a relatively easy measure. This is talking up to Nicholas that he will give us some better machines in the future. But generally speaking, I think it's very easy to measure. I think it's quite feasible. I will be able to tell you soon, for example, in Down syndrome, whether it's easy with those patients, but we believe it is. And the reason why I'm excited about it, because it's this thickening of outer retina and loss of cones is quite a sensitive measure to look at inflammation, which is one of the early events in most of these neurodegenerative conditions, even Alzheimer's and Down. So it probably has a more specificity than looking at the later changes, for example, atrophy.
Thank you very much. Anyone else can pitch in, but Frederica, someone texted me a question saying, so what happened to those patients who you couldn't image? Could you rule out inflammation there, or were they simply just unimageable because of all sorts of other reasons?
So sorry, I didn't get the whole question, but I think I understood.
The people were a bit worried that you said that you definitely didn't have inflammation and you can rule it out, but you haven't been able to image everyone. So I suspect you have a slit lamp examination on the others, and you knew.
Yes, yes. So we also did, of course, a clinical examination at the slit lamp. We also try to include now, as like in genetic treatment and for Luxuna, there is also the atrophy now in the images, and we also try to perform angiography, but unfortunately we only had 2 patients that were willing to perform it, and most patients or most eyes we included were earlier than this observed atrophy. And so unfortunately, we don't have good data on that feature. But yeah, of course, we didn't see at the slit lamp any measurable inflammation.
Thank you. So Michelle was first.
You are muted, Michelle.
You are muted.
Yeah, since there are more and more concern about intraocular inflammation in many trials, in particular, even in the geographic atrophy intravitreal treatment that is being approved by the FDA. I think the adaptive optics can bring valuable information and maybe extend it to other type of intravitreal therapy to be sure that they are not inducing and hence maybe aggravating AMD. I'm not talking about the specific topic of gene therapy, but in general. So I think it has what your work can be extended to many other diseases and become a standard for these trials.
I agree. Yes.
Thank you. So you both advocating for using the vascular measurements and the vascular information that we have in the images more widely.
Especially in veins. In fact, you looked at artery, I think, but I think also it would be great to look at veins.
Great. Nicholas?
Yes, I have a question for Imre. So first, I got your message about keeping on improving the system. I wanted to ask how you rule out that the reduced density of cones that you observe might also be due to a reduction in the visibility of cones due to changes in the more inner retina.
That's a very good question. Based on the images, which the only thing we can go on, we don't seem to have any changes. None of the other modalities or on RTX we see that problem. But of course, what would be really fantastic to have is a rod measurement alongside the cones, just to see. And also it would be nice to see with some functional testing, and I think that will be the important next step, to get some functional information on whether this is a general dropout, some cone-specific dropouts, or what's happening really. So I don't think it is, but I cannot rule out.
Marie-Hélène, did you have a question? Is that right?
Yes, I had a question for Dr. Hélène Guillaume. When we see patients with MS, many of them, they have no symptoms, but they have inflammation of their retinal vessels. So there is an ongoing inflammation that is asymptomatic. Are you thinking of comparing your cohort of patients with no optic neuritis to see if they are losing their outer retinal function as well? Because it might not be the loss of cones, might not be related to optic neuritis, but just to the ongoing inflammatory disease.
So we do see the same cone loss, whether the patient had optic neuritis or not. So we also had very limited numbers who were on disease-modifying therapies, especially for inflammation, and those don't seem to let's say improve or change the cone dropout. In fact, probably it's higher in those patients, but the numbers are very small. So I do believe that it's part of the inflammatory process, but it probably not vascular in this outer retinal space, because we don't see choroidal changes so far that would underpin that.
Okay, thank you.
Well, of course, we'll all need slightly bigger cohorts than what we have, and anyone who has AO machine and is able to do good quality images, that would be great, because of course some of these patients do struggle to be sitting at the camera, and some of the younger patients treated with gene therapy, they might have slightly different problems as well. And so overall, the more that we put our cohorts together, the more likely we are going to be successful in getting to the bottom of some of these issues around the care for, and then we might be able to see how we're going to be able to use this technique in everyday clinical setting that is not available, unfortunately, for all of us at the moment. So I'm going to look at Marine if if we're roughly on time, we're sort of 1 minute ahead at the moment. If anyone has any burning questions, then please do. Otherwise, I'm going to hand it back to Maureen and Nicholas.